Thank you for selecting our abstract, and thank you for Dr. Ahmed Al-Absi, who is the team leader for this project, and he's the one who wrote the proposal, the abstract, sorry, not the protocol. So as a background, we know that the introduction of pediatric-like regimen to manage adults with acute lymphoblastic leukemia has shown promising outcome among several analyses. This is a combined study between King Abdulaziz Medical City Riyadh and Princess Noura Oncology Center Jeddah, where before the two centers used to give patients from 14 years and above with newly diagnosed acute lymphoblastic leukemia hyper-CVAD protocol. But after 2016, we started to use this protocol, which is on a backbone of BFM, German protocol, with 7 steps, modification steps with an aim to improve the efficacy and reduce toxicity in the adult group. And I will go through those steps first before we go to our protocol. And then, after we got an IRB approval, we compare the result of those patients who were treated with the modified protocol versus those who were treated traditionally with hyper-CVAD. So those are the 7 steps that we went through. So the first step is the use of pre-phase steroid and dexamethasone in induction, asparaginase modification, the use of high-dose methotrexate in interim maintenance, whether it's B-cell or T-cell, the incorporation of MRD in decision-making, and use of blinatumomab or nilarabine for MRD-positive patients, elimination of second phase of delayed intensification, incorporation of rituximab for B-cell, and 30 months maintenance duration. I will go briefly through those steps to make it clear. So the use of pre-phase dexamethasone, the aim of that is to give time for the PCR able to turn out, because as you know, we are excluding Philadelphia positive chromosome, and the use of DEXA instead of prednisolone. In the original BFM, they used prednisolone in induction. Here we use dexamethasone. The rationale is that DEXA is has more CNS penetration, and as well, it has less risk of relapse. However, we know that dexamethasone is more toxic than prednisolone. That's why in the induction, antibiotics, antifungals, and G-CSF were added. Asparaginase is a very important medication in most of pediatric protocols. However, the adults don't tolerate asparaginase like children, and that's mainly because of, I will go back, because of liver toxicity. Liver toxicity is affected mainly by the body mass index, increased age, fatty liver, and the dose. That's why we capped the maximum dose to 5,000 units. There was an age-adapted scheme, so those who are less than 25 years will receive the full dose, while those who are more than 25 will receive reduced dose. There was further reduction in the dose of asparaginase to a total of 1,500 units per meter square if there is fatty liver. So we obtain an ultrasound. At the beginning, this was moderate or severe fatty liver. There is more modification. The asparaginase we use is a big asparaginase. Erwinia, we use it in case of allergy. Since studies showed no difference between IM and IV route, we choose the IV route to avoid the bleeding during the thrombocytopenia. In the original BFM, they use high-dose methotrexate for T-cell ALL, but for B-cell, they use the Kabizi methotrexate. But the COG ALL 0232 study compared high-dose methotrexate with Kabizi methotrexate, and they found that high-dose methotrexate has better overall survival and even free survival in high-risk ALL, regardless whether they are B or T-cell. So we incorporated high-dose methotrexate in the protocol to both subtypes of ALL. And we use a smaller dose for those who are more than 25 years, and 5 grams per meter square for those who are more than 25 years. We know that recently MRD became the only or the most important prognostic feature to decide on high-risk features and the need for transplant. So MRD after consolidation is the only indicator for transplant to our patient, regardless of their initial high-risk features. And we choose MRD after consolidation, which is after 3 months of starting treatment as an indicator for transplant. We have the cutoff of 10 to the power minus 4. Both centers, we do it by flow cytometry, 8-color flow cytometry, with the sensitivity of 10 to the power minus 4. And also, for those who are MRD positive, if they are B-cell, we'll go for blinatumomab and then off-protocol transplant. Since there is no standard of care in T-cell ALL eradication of MRD, we selected to choose either nilarabine, single agent, or high-dose methotrexate, just to try to put them in MRD negative before transplant. Also, the CCG 1961 study found that there is no benefit of delayed intensification phase 2 when it comes to event-free survival. So to reduce the toxicity in this adult group, we decided to omit that part from our protocol. And also, studies showed that use of continuous steroid has more risk of osteonecrosis than use of intermittent steroid, so we changed the protocol to intermittent steroid also. Rituximab is used for those who are CD20 positive in the hyper-CVAD group, but here, and because of the theory of CD20 upregulation after exposure to steroid, we decided to give it to every B-cell ALL, whether they are CD20 positive or negative. And the optimal duration of maintenance selected in our protocol was different a bit from the BFM protocol. It's 2.5 years, not 3 years, not 2 years. Now we'll go to our protocol. So our inclusion criteria was newly diagnosed patients with Philadelphia negative ALL or T-cell ALL. They should be from 14 to 40 years. They should have adequate organ function. Patients with Down syndrome or Philadelphia positive or above 40 are excluded. Our primary endpoint is the overall survival and disease-free survival. Our secondary endpoint is toxicity, MRD eradication after consolidation, and the rate of transplant. So this is the general patient flow. So as I said, there are 3 to 5 phases of pre-phase of steroid. We are giving IT, but after the lecture yesterday, maybe we'll postpone the IT in the future, we'll amend the protocol. And then the patient goes through the induction phase. After induction, we do bone marrow to check for remission. And after consolidation, we do another bone marrow to check for MRD. And if patient is MRD positive, off protocol. If MRD negative, we'll go through the phases of the protocol. 58 patients were selected from the 2 centers in the BFM protocol. These are the general features, characteristics between hyper-CVAD and modified BFM. As you see, the total number of patients is 103 from the 2 centers. Hyper-CVAD had 45 patients from the same age group, and modified BFM, 58 patients. The general characteristics are the same between the 2 patients, and the demographic is the same. However, there are more risk of complex cytogenetic, more complex cytogenetic cases in the modified BFM. More patients in the modified BFM received received rituximab than hyper-CVAD, and this is explained because those patients we give to B-cell, whether they are CD20 negative or positive, while there we only give to CD20 positive. 0 patient received hyper-CVAD, and this is of course because received blinatumomab in the hyper-CVAD, and this is because in 2016 when we stopped using hyper-CVAD, the blinatumomab was not yet approved for MRD clearance. It was approved in 2018. The result, the median follow-up for the hyper-CVAD was 39 months, for the BFM 41 months. There were significant rate of MRD positivity in the hyper-CVAD than the BFM. So in hyper-CVAD, 26%, almost third of the patient had MRD positive after consolidation, while in BFM, only 10% had MRD positive after consolidation. More patients in hyper-CVAD group went to transplant, so 40% of the patients in the hyper-CVAD went to transplant, while only 12% in the BFM had a bone marrow transplant. Our 5 years overall response rate was in favor of BFM, so the BFM protocol showed 83% 5 years overall response rate versus 65% for the hyper-CVAD, with a significant p-value. Also, the disease-free survival rate was 67% for BFM protocol versus 44% for the hyper-CVAD, again with a significant p-value. When it comes to toxicity, the toxicity regarding the neutropenia and the ICU admission were the same between the 2 groups. However, liver toxicity was more in the grade 3 and 4 liver toxicity was more in the BFM protocol. And of course, this is most likely related to the asparaginase. And also there were 5% risk of pancreatitis and 0% in the hyper-CVAD. Osteonecrosis, there were 20% cases of osteonecrosis in the BFM protocol and only 2% osteonecrosis in the hyper-CVAD. But this is not really fair because in the BFM protocol, this is part of the protocol to do bone density assessment, and we are looking for osteonecrosis before we start maintenance, while in the hyper-CVAD, we did it only for one patient who was symptomatic. But maybe if we are doing it the same like in, we will detect more cases. For the causes of this because of sepsis were the same was the same in between the two groups, but this due to disease progression was higher in hyper-CVAD, 24% versus 3% in the BFM. Okay. In conclusion, our analysis demonstrated that the use of pediatric modified protocol has superior outcome when compared to hyper-CVAD. The modified BFM protocol was associated with increased risk of certain toxicities, including high-grade liver toxicity. This might need more modification in the asparaginase dose, maybe. Larger multicenter prospective randomized trials are required to accurately compare adult and pediatric inspired protocol. And with the current data favoring moving novel agents to frontline protocol, the protocol is suspected to further modification, and maybe we'll add novel agents. And we have published our data in leukemia research a few months back. And I would like to thank my colleague. Without them, the work would not be possible, from Princess Noura Oncology Center, Jeddah, and National Guard, Riyadh. Thank you so much.